Good evening. My name is Jim Greenblatt, and I'm pleased to share some information with you about our programs at Psychiatry Redefined, and specifically on a functional medicine for primarily trichotillomania. We'll be talking about just a bit of background. If you're new, Psychiatry Redefined is a educational platform devoted to helping clinicians understand functional medicine for mental health. I spend a lot of my time on calls with doctors from around this country and the globe, and everyone has questions of different concepts of what is integrative medicine, what is functional medicine, and quickly, integrative medicine are all those lifestyle modifications, diet, exercise, mindfulness, all things that have been shown to be incredibly helpful for mental health and mental wellness. Functional medicine is root cause, is genetics, is the gut, is understanding hormones, nutritional deficiencies. It's a powerful modality that's really growing in the rest of medicine, but there's nobody teaching clinicians functional psychiatry. So tonight, I'm using this, trichotillomania and other kind of hair pulling and skin picking as a path to help you understand functional psychiatry. And this is always a fun topic for me because we have no currently approved medications for body focus repetitive behavior disorders, which we'll go over. Hair pulling is the most commonly discussed. And we have behavioral treatments that work okay, but there is so few people who are expert in it. So functional psychiatry has a unique opportunity to help so many patients. And I'm going to primarily talk about three things tonight. I'm going to talk about the gut. I'm going to talk about NAC, which most of you probably have heard of, and then lithium, low dose lithium, which I'm sure many have not heard of in relationship to trichotillomania. But here's it's always fun to start with a case. And we wrote an article on a individual who had severe OCD that was completely resolved by treating a gut dysbiosis. And we included objective laboratory testing and the treatment protocol. And it was written up, this probably was 15 years ago. What happened is this gentleman, and this is a quote from his website, How I Cured My Hair Pulling. He read the article. He was, I believe, a 40-year-old male, and these are quotes from his website. He sent me a letter at the time. I happened to stumble onto an article about a psychiatrist treating OCD patients with probiotics. My recent hair pulling is certainly like OCD. He started taking Brand X, an over-the-counter probiotic, 30 billion capsules a day. And as of today, not only have I been symptom-free, but I've never had to apply any willpower to help me stop pulling. The urges have completely disappeared all by themselves. I took no psychiatric medications nor any psychological treatment. Nothing except the probiotics. Now, this gentleman, didn't want to mention the brand, but it's just a powerful example of something that we've been doing for many, many years, and we'll talk about this in detail coming up. But completely cured trichotillomania by taking over-the-counter probiotics. Now, I don't think that necessarily will help. Well, I think it'll help everyone, but it's not sufficient, and that's what we're going to talk about. So, I'm used to the term trichotillomania because I've been treating it for almost 30 years, but we have body-focused repetitive behavior disorders, which is a cluster. These are compulsive, repetitive, non-cosmetic behaviors accompanied by distress and or functional impairment. So in the DSM, we put them under these OCRDs. Okay. So again, I talk about hair pulling because it's most of what would reach my office. The nail biting, nose picking, skin picking, we see a lot in the hospital, or other body focused repetitive behavior disorders, lip, cheek chewing, finger sucking, joint cracking, teeth grinding are, again, some of these BFRBs. The most common is actually skin picking, nail biting, and lip and cheek chewing. Again, most of what my experience is with the trichotillomania, and then the skin picking is usually not what people come in for help with, but we see it all the time. And this is an important question that every researcher asks: does anxiety and distress fuel those compulsive behaviors, or does the behaviors cause anxiety and distress? And when we think of functional medicine, when we think of root cause, this question is not as critical as some researchers might want to, unfold, because these compulsive repetitive behaviors in a functional world is driven by biology. And we are looking at what that underlying biology is. There's clearly a genetic vulnerability, and clearly there's environmental factors. So the chicken or the egg is not really the question. The question is really, what is the root cause? Okay, so we're going to focus on trichotillomania. The treatments I'm going to share are appropriate for all these disorders. So recurrent pulling out of one's hair, resulting in hair loss. Repeated attempts to decrease or stop the pulling. The pulling causes significant distress, not attributable to a medical condition or another mental health condition. Now, like everything else in the DSM, what does this tell you about how to treat it? Right? This is just a list of symptoms. And we just check the box. Okay, this person has trichotillomania. There's no concept of etiology. There's no concept of objective testing that somebody could look at to develop a treatment plan. And that's what we focus on in functional psychiatry. So trichotillomania is not only for girls, it's more common in women, certainly in the older ages, but we see it in both men and women. It's not part of grooming, and it's not the same as OCD. It is not uncommon that we see trichotillomania with ADHD, PTSD, OCD, and other kind of mood and anxiety disorders. The implications are pretty significant, particularly for young kids, but there's avoidance, there's decreased academic, there's low self-esteem. Why can't I stop? There's a risk of addiction and further increase in anxiety and depression. So, it's approximately 2%, of the population. It's not huge, but it impairs and many young adults' lives. There's also much more common than we think. trichophagia, which is actually eating, the ingestion of the hair once it pulls. Some just ingest and spit it up. Many swallow it, creating a whole host of GI problems. But that's 20%. And the vast majority never seek treatment. That's why, as a child psychiatrist, I had somebody bring the child in. But as we get to adolescents and adults, it's embarrassing, and people don't seek treatment. So I already picked on psychiatry and the DSM. It's a bunch of symptoms with no objective testing. And here's where it gets interesting. The treatment model is medications and therapy. But as a psychopharmacologist, I guess you could say, my career, understanding and prescribing medicines and teaching residents how to prescribe medicines, we have no medications approved for trichotillomania. And similar to the world of anorexia nervosa, every medicine's been looked at. So we have the SSRIs, naltrexone, Abilify, Zyprexa, even Ritalin, Trileptal, even THC. I mean, the list is quite long with some, and then an Alzheimer's drug, memantine. And some of the medications have shown some benefit in one study, but not in another, hence no FDA approval. N-acetylcysteine we'll talk about as a nutritional supplement, which probably fares better than all the medications. And then the therapy, we'll talk about some habit reversal therapy. But patients get a little better, but the underlying biology continues, and this compulsive need to pull continues. So there are a couple different psychological interventions. The habit reversal training is probably the most effective. We try to eliminate the hair pulling by replacing them. It could be with some squishy doll, or there's now some bracelets with apps that are monitoring. So there's lots of opportunities for habit reversal. And then stimulus control is just much more deeper dive into cognitive behavioral therapy, looking at triggers and help modifying that. Again, talk to anybody with trichotillomania. These behavioral interventions sound great. They can be helpful. They take a lot of work, and typically you get a partial benefit. Again, the habit reversal training, people become aware, and they're looking for something else to pull, if you will, rather than the hair. They help, and I'm not dismissing them. They can be effective. The most effective tools are both the behavioral therapy with a functional medicine approach. Oftentimes, we can eliminate the need for medications completely. So I'm convinced we can do better. Think about it for a minute. We're just using Band-Aids to stop a compulsive behavior that oftentimes is quite scarring and debilitating for some patients. And functional psychiatry just adds this objective biology into the equation. So rather than these educated guesses, because there's been one study done or two studies on a medicine, or many, many months of therapy with partial response, when you use functional psychiatry, you really can hit the bullseye. And again, we know everything on this slide, that abnormal thoughts and behaviors like compulsive pulling, they have genetic, metabolic, psychological, nutritional deficiencies. We'll talk about the gut and immune response, and environmental chemicals, from mercury to cadmium to copper to lead. The list goes on and on. So we have all this information, right? Some of this goes back 30 or 40 years. How long have we been saying Any amount of lead affects brain function in kids, dramatic increase in ADHD and other neurodevelopmental disorders. How long can we keep saying it until it's part of a clinical practice? Till it's part of the world that we're teaching and training our young doctors, our young nurse practitioners, our clinicians. So the core concepts of all functional medicine, which is frustrated and why our training takes time and energy, is every patient is different. 10 9-year-olds with trichotillomania. I'm going to share with you some general concepts about the gut and NAC and lithium, but we can find a whole host of nutritional and metabolic problems contributing to that, to an individual's trichotillomania. So functional psychiatry looks at the individual. So let's start off with the case that I presented, that 40-year-old with trichotillomania, and let's chat about the gut. So certainly now it's being discussed a lot. Billions and trillions, I guess, friends you didn't know you had. Nobody has the same microbial makeup. And we know that there's more nervous tissue in the gut than in the brain. And a lot of the neurotransmitters, 95% of serotonin, 50% of dopamine, is produced in the gut. So when we think of dysbiosis, if you will, or abnormalities in the gut microbiome, we can see that there's a profound connection to the brain. So we kind of generally use this term dysbiosis, and all we're saying is that the normal gut bacteria is off. And we've looked at this now for many years in psychiatry. And the good news is this is one area of functional medicine that there's just global interest in looking at the research. So we know dysbiosis, abnormal gut bacteria, contributes to these major psychiatric illnesses: psychosis, depression, eating disorders, bipolar disorder, ADHD, Alzheimer's, and not a lot of research, but clinically, certainly trichotillomania. So there's some decent research on OCD. This is just one of the studies here. You see medication-free OCD patients compared to control and decreased microbial diversity. And that's one of the keys across all these disorders affecting brain function, is decreased diversity of gut microbes. We know there are a lot of reasons why somebody would have dysbiosis in the gut, from infections, from diet, alcohol. The most common in my career as child psychiatrist is the use of antibiotics in kids, laxatives, steroids, stress, and just general poor nutrition. So there's lots of paths towards dysbiosis, and the research has also demonstrated improvement in anxiety, depression, mood, and OCD. And then I just use this slide to help people see the impact of probiotics. It has pretty significant effects on multiple neurotransmitters: GABA, acetylcholine, dopamine, serotonin, and tryptophan. And here's not just dysbiosis, we can induce OCD in rats. So they have these compulsive behaviors. And here, probiotics plus the medication displayed reductions in OCD. So I want to talk to you about a particular marker that we can detect in a urine test, the urine organic acid, that was the basis for that article we wrote on OCD, where that gentleman started taking probiotics. So we're not saying just go take a probiotic. That's more an integrative psychiatry approach. Probiotics are good. A a functional psychiatrist wants to know how and why. So for all of our patients, we recommend our organic acid test, which looks at 70 plus metabolites of the body, many of microbial metabolites of yeast and bacteria. So we're looking at one in particular, and don't ask me to pronounce it. We'll just call it HPHPA. And it's a byproduct of the metabolism of certain species of Clostridia. Okay, there's normal Clostridia species in the gut, and they're hanging out doing their thing. And there are some species that are bad for us, dangerous, like Clostridia difficile, causing significant GI symptoms. And there are some strains that produce this HPHPA. And this particular chemical that we can detect in the urine has profound implications for brain function, OCD, and trichotillomania. So this is just kind of a schematic. If you just follow the little positive blue marker, you see the Clostridia is the red, and these are in the gut bacteria wall. And this HPHPA is absorbed into the bloodstream and filters in the kidney, and we can detect it in a urine sample, an organic acid test. HPHPA has profound implications for brain function. This molecule disrupts the conversion of dopamine to norepinephrine. What does that mean? Well, we don't know all the details, but there's a buildup of dopamine and people feel miserable. And there's a whole host of mental health symptoms. And we did a study in our outpatient clinic a number of years ago. So we got about 120 of random visits, or we collected them, and we had them pee in a cup to look at this organic acid test. And we didn't find everybody that had elevations of HPHPA, but it was about 15 to 18%. So those coming in to see a psychiatrist. And the symptoms in front of you were some of the symptoms, not diagnoses. These are the symptoms that people reported with elevations of this marker that we can detect on a urine test, HPHPA. So again, almost 150 patients, some had many, but you see skin picking, OCD, anxiety, more OCD, and impulsivity. We're going to talk about that. Okay, so these are the 15 to 18% of patients who had a positive HPHPA. Okay, and these were the diagnoses. Okay, so it's a simple urine test. And what do you do if someone has elevations of HPHPA? Well, first of all, my clinical experience looking at this test for over 25 years, I can tell you, you don't feel well. You're anxious, you're agitated, and let me just go back to this. I mean, these are some of the symptoms that we see. Almost everyone is driven by irritability and anxiety, and some with DSM diagnoses, others just with symptoms. Urine test easily detected, profound implications. And how do you treat it? Well, there are a couple paths. First of all, at least for a couple months, we use high dose probiotics. High dose typically start at then sometimes 100 billion has a measure use. It's called colony form, usually in the billion, but we try to get a couple 100 billion off slowly. Again, starting usually with 50 billion, 100 billion, and then titrate. Often that is, but this Clostridia is so significant for many symptoms. I listed many of them, that if for 2 or 3 months, probiotics, not the HPHPA, we actually look at antibiotics. And the two are vancomycin and Flagyl. We're not going to go through details in this web, through this in our fellowship, but it's typically a 30-day course. And because you want to be able to kill bacteria and the spores, and you take the antibiotic one day and then 2 days the probiotic. Again, trichotillomania, OCD, commonly associated with elevations of HPHPA. And then the punchline in all the research, from Alzheimer's to anorexia to obesity, we see different microbial strains, but those disorders are typically associated with less diversity. So a whirlwind tour where we have hundreds of hours of content on gut dysbiosis and how it affects mental illness on Psychiatry Defined. But I just wanted to share with you that case and the mechanism, looking at an organic acid, objective test, elevations of HPHPA. We can treat it with probiotics, if needed, antibiotics, root cause analysis. Again, you've probably not heard much about the dysbiosis, but I'm sure everyone has heard about N-acetylcysteine for the treatment of trichotillomania. There are some research studies. It's not always listed as a frontline drug, but it is usually the first that people go to. One, because it's a supplement and the side effect profile is minimal. So it is a cysteine, which is an amino acid with another chemical structure, so it enhances absorption. It's unclear. NAC has powerful implications across the brain. It's a major antioxidant. It is the precursor to glutathione, most abundant antioxidant, and also stabilizes glutamate, which is likely one of the factors in some of these compulsive behaviors. So glutathione is important. Again, the mechanism, it's unclear, and NAC does also modulate serotonin. There's kind of lots of paths. And most of the studies, and again, even though it's a first treatment, if you really look at the research, it's not always consistent, and it doesn't always help. But this was one study, 50 adults, randomized, placebo-controlled, and some were taking medications, some were in therapy, and so it was treatment as usual, which is hard to think of a research study because you don't know what else they were taking. But those that took NAC, 56% were much or very much improved, which is just a very general checklist, but statistically significant compared to placebo. Now, the other studies looking at NAC here, just a case study. The dosage is going to be important. This was only 1.2 grams. Positive results maintained at 6 months. And here's 2019 studies looking at what's called a meta-analysis. And again, this slide's important to share with you my experience and the research that this does not always make a dent in the first 2 to 4 weeks. It takes a while, so be patient, at least 3 months. This treatment period in this meta-analysis was 1 to 8 months. And then the dosing is also important. Most of the studies really have demonstrated better results with dosages over 2 grams. So this 2,400 milligram is, in my clinical experience, closer to the correct dose. So starting off low, N-acetylcysteine comes in 600s. You might start off with 1,200, and assuming there's no GI side effects, you can increase. Typically, with these behavior disorders, you go slowly. So it could be every couple of weeks, but resting on the 2 to 3 gram amount for trichotillomania. And here's the summary. This was of this meta-analysis in a dermatology journal. So NAC, we learned a lot about COVID. It's been studied across the globe for everything from PTSD to schizophrenia to bipolar depression. It has profound implications. Too often, we just throw it into the mix, but it can be helpful. And again, the dosaging is at 2 to 3 grams, and be patient. I shared with you it's not a quick fix. You need to give it the 3 to 4 months, but easy to add on to medications or in place of medications. Again, it's a precursor to glutathione, the most abundant antioxidant, certainly in the brain. So I shared a little bit about dysbiosis. I shared a little bit about NAC. I'm happy to take questions. But now I want to talk about something that, if you know me, I talk about a lot, but is nutritional lithium. It has profound implications for hair pulling, skin picking, and other kind of body-focused repetitive disorders. And whether we're talking about nutritional lithium or pharmacological lithium, many researchers can describe micronutrient, this medication, as a anti-impulsive drug, right? Think of impulsive behaviors from bipolar disorder. It works on that mechanism. There's MRI scans of patients with trichotillomania, so brain regions are focused with impulsivity were diminished, and lithium targets impulsivity and irritability. So just briefly, when I'm talking about lithium, I'm talking about a nutrient. We have lithium carbonate is a medication. We have lithium as an element in the periodic table that's used in everything from cell phones to airplanes to the fireworks. But when we think of impulsivity, to act without thinking or potential consequences, and certainly trichotillomania fits into that. And this dysregulation of the brain's impulse control mechanism is believed to be a significant contributor, both clinically as well as I shared with you some of the MRI studies. And, we look at it. This was a study done last year looking at self-regulation, higher impulsivity, and you can measure impulsivity from many computerized tests, and this was worse performance of those that had trichotillomania. Study of 43 young girls, aged 12 to 18. Okay, impulsivity is important, and we know lithium is incredibly helpful for not only stabilizing mood, but also impulsivity. And, I don't have great research on nutritional lithium, um, but with prescription lithium, we have improvement in impulsivity associated with aggression. And then we have a Japanese study looking at lithium levels in the drinking water, which showed improvement in interpersonal conflict. So lithium does anti-impulsive things. The other important things about lithium: it reduces inflammation, it's anti-inflammatory, produces brain-derived neurotrophic factor and other kind of healthy peptides in the brain. And it also decreases glutamate, similar to N-acetylcysteine, which many believe might be one of the mechanisms that helps with trichotillomania. And what I'm sharing with you is nutritional lithium. There are occasion, I have a couple of patients that have been hospitalized where we did use low dose lithium carbonate, 150 milligrams. But when we're talking about trichotillomania, most of the time we can get great results with lithium orotate. I start typically at 2 milligrams to make sure there's no side effects, and then titrate up. And some people end at 2, 5, or occasionally, they might need 30 milligrams. Lithium, like NAC for trichotillomania, can take time, can take 8 weeks. For some symptoms like irritability, it can take just a few weeks. Again, I use carbonate, low dose, 150 milligrams, as I would orotate. The carbonate, a dose of 150 milligrams, is 28 milligrams of elemental lithium. So once I get above 30 milligrams, I switch to carbonate. Okay, so I took you on this journey of trichotillomania and body, repetitive focused behaviors. And I just want to share with you, it's been a large part of my practice for many, many years. And this functional psychiatry approach has just been kind of mind-boggling in how these symptoms disappear. And patients over the years don't always present with hair pulling or skin picking or nail biting, but we're treating their ADHD, we're treating their OCD, we're treating their panic attack, and these behaviors disappear. And it's just, I think, a powerful example of the role of functional medicine. Too many patients blame themselves. Too many parents blame the kids. Just stop. Willpower. And these are biologically driven, compulsive behaviors that are treatable, and particularly with a functional psychiatry approach. In Psychiatry Defined, in all of our programs, and I'd be happy to answer questions. And we have educational consultants who can kind of meet and talk with you to see which program valuable. We have our adult general fellowship starting in July and our pediatric in August. But the core concept that we teach from day one, and then in the last lecture, is this in front of you: biochemical individuality. Everyone's different. So, we're talking about trichotillomania. Let's just say these 5 young women, all 9-year-old girls, present with trichotillomania. We might have one that has a dysbiosis problem and we're using probiotics. Number 2 might have multiple nutritional deficiencies, like vitamin D, a precursor to serotonin, important for compulsive behaviors. The next one might have, environmental toxins and low zinc. The other one might benefit from lithium. We typically predict lithium use based on family history of addiction. So maybe this woman presented with multiple generations of addiction and started pulling hair. That's the perfect patient for nutritional lithium. So everything we do is based on looking at the individual. Everything we teach is helping you as a clinician look at the individual. It's what you would want for your loved one, for your family member, rather than just guessing which SSRI, or nowadays in integrative medicine, which supplement. You don't have to guess. We can look at these functional tests. We can look at organic acid tests and look at levels of HPA. We can look at levels of lithium. We can look at NAC excretion. There are, I think I counted 250 biomarkers that we like to look at and talk about as we report these personalized treatment plans. So functional psychiatry just means we have more tools in our toolbox. We certainly can appreciate integrative medicine and lifestyle, psychiatry, certainly appreciate the role of therapy and certainly habit reversal and cognitive behavioral therapy for trichotillomania. There is a role for medications. The research is so weak. It's very unusual that first-line treatment for trichotillomania would be medication. Nutrition, nutritional deficiencies. They support the synthesis of serotonin and every other neurotransmitter. And you always looking at genetics of how we metabolize drugs, how we metabolize nutrients, and then just the family history. So functional psychiatry is what we teach and what our patients are desperately looking for. So this is the fellowship. I'll just share a little bit and then hopefully answer some questions. And again, please sign up for a one-to-one call where we can talk with you about what might be best for you. But the fellowship functions as a year-long educational program with recorded content, with live supervision, with mentoring groups based on discipline. There's practitioners get in a group, naturopaths, psychiatrists. But I think the richest part of our programs is the community, are the clinicians that are interacting daily. People are posting challenging cases, problems, side effects, and they're getting answers from the faculty and from other members of the community. So what I think we've done a pretty good job at is provide you different tools for learning functional medicine for mental illness, functional psychiatry. There are programs out there. I saw one ad where the headline is, "You don't need a fellowship. You can learn this in a weekend." And this second part of the ad was, "We can make you rich by learning a few integrative psychiatry tricks, like how to prescribe a supplement." And the reality is, understanding this material takes time. But your patients deserve it, and I know you want to improve outcomes. So again, functional psychiatry, looking at root cause. We can do a lot better than our current polypharmacy, symptomatic-based, educated guessing. So I hope I shared a little bit about how we treat trichotillomania. We look at low-dose lithium, we look at NAC, and we look at the gut as just three of many, many paths. So I'm going to stop here and try to get to the questions. Well, here's an interesting one. Popping pimples on the face fall into that category. I would say for some, absolutely. For others, maybe not. Again, these are behaviors that, um, are disabling or and functional impairment to it. The some people benefit from the habit reversal training. Um, there are programs, and it works. In my experience, without looking at the underlying biology, that too often it slips back. But it certainly, we know the behavioral therapies work. I don't think we're quite there as to which probiotic strain does influence which neurotransmitter. That's why I think some of the testing and some of the hype is a little over what we do know clinically. I do think the critical piece that is found in every study is that the decreased diversity. The stool test doesn't always pick up, certainly doesn't pick up HPHPA, because Clostridia is a normal part of the gut flora, so a small amount would not be seen as a problem. So stool testing, I just haven't found as the critical test in our kind of initial psychiatric workup. Someone's having significant GI problems, maybe, but the organic acid looks for byproducts that affect brain function. There's very few confounding variables for HPHPA. It's either positive or not. Good question. Someone asked, HPHP worse for slow metabolized? Absolutely. Yes. If dopamine is built up and you don't break it down, you get more anxious. HPHPA, someone asked a specific question. I think if it's anything close to 200, I would worry about it. If you do enough of them, you'll realize they're very, very low. Um, Someone asked about trauma, and sometimes when we understand the tragedy that some of our patients have gone through, whether it's abuse, certainly the most common, we tend to put all our eggs in the psychological trauma basket, and we're compassionate, and we listen, and we recommend therapies that we think will help trauma. But I'm not quite sure why we have blinders to the biology. Somebody that's had trauma can still have celiac disease, a B12 of 200, a vitamin D of 6, or elevations of HPHPA, which compounds the symptoms and really hinders treatment and recovery. So much of our psychiatric patients struggle with trauma, and some meet criteria for PTSD, but don't let it kind of slow you down in looking at these nutritional or functional markers, because improvement is just much more rapid. It's actually dramatic treating trauma when you introduce functional psychiatry. I'm not sure the cost. It's around $200. You can get just the microbial organic acid, but it's not covered by insurance. With another question. NAC for a 10-year-old, I would start with 600 milligrams once a day, then 600 twice a day. I think pure encapsulation has a 6 and 900 milligram of the NAC. Good question. How long does someone have to stay on NAC? Um, Usually it's a while. So let's just say 6 to 12 months. If you're fortunate to do kind of behavioral therapy with it, it's much more likely that you'll be able to taper off of it. But it's usually a minimum of 6 months. But once the behavior has been contained, the nerve circuitry improves, um, and things are just better. So combining it with habit reversal would always help. Yeah, I don't have particular strains that I'm going to recommend a pre and postbiotic. Um, Nursing mothers, great question. I would not recommend lithium. I think it's safe. Um, but since we don't have the research, I don't think one would recommend lithium. And NAC, um, I'm pretty sure it's safe, but I would check with your doctor. Again, for kids, the lithium and the NAC, usually we can stop it in that 3 to 6 month period. For adults, it's usually longer term. And yes, nutritional lithium can absolutely be taken with Wellbutrin and Adderall. Yes, no, the lithium orotate is best when taken daily. So someone said lithium, Wellbutrin, Adderall, 2 months on NAC were not helpful. Well, I mean, that's not uncommon. Again, we have no medication that we know has been helpful, and NAC is not consistently helpful. So that's where functional psychiatry comes in. That's where we teach clinicians how to test. Maybe it's a dysbiosis. Um, Maybe it's a different medicine that's needed. Maybe it's a B12 deficiency. Maybe it's a cryptopyrrole. I mean, the list is endless. We have hundreds of markers that we teach clinicians how to assess, and more importantly, how to help patients improve outcomes. Lithium orotate, you don't have to monitor hair. Anyone on lithium, we want to look at blood levels, carbonate or orotate. Orotate, you shouldn't have any. Carbonate, it should be very low. So success rate for me, a biochemical approach. Um, if someone comes into the office saying, I want just medications, one, I won't treat them any longer, but the success is 50-50. If someone comes in saying, I want just supplements, success is 60-40. If someone comes in saying, I'm open to whatever is going to help me or my child, I mean, I think this functional psychiatry approach is way above 90% because we're not eliminating the need for medications. We're just looking at the underlying contributing factors that are contributing to the OCD or the trichotillomania. So my experience, 30 plus years, there's no other path that I think one can help somebody who's struggling with a mental illness, particularly someone who didn't respond to medication. So we're going to need to stop. A lot of great questions. I apologize we couldn't get to all of them, but at least we have a really interesting group thinking, asking great questions, and hence our fellowship program takes time. That you can't learn it in a webinar and you can't learn it at a conference, but you can learn this material. And we have programs and mentoring groups and interactive sessions to teach you how to test and interpret the testing. So I'll leave you with this last thought about trying to book a call with one of our educational consultants who can kind of help sort through our different programs. We have trainings at every level and every mental health discipline. So I really appreciate everyone taking time. To me, it demonstrates that there's hope that we're going to kind of move this needle and improve outcomes, and let us know how we can be of help in your practice. Take care. Have a great night.